So in the last class, we discussed about preventive orthodontics. It was an introductory class, but we covered a lot of things. In today's class, we'll focus on the space maintenance, which is one of the preventive orthodontic procedures. So during the class, if you have any questions, you can uh, either speak using your mic or you can use the chat function. I'll try to access the chat. Last time I was not able to do that, but today I'm trying to figure out from where I can access the chat. Okay, now I can see where you all would be writing any questions. So let's begin. Mm, yeah, let me go back. So these were the procedures that we discussed in the last class, starting from parent education to the management of abnormal frenulum attachments. We discussed almost all of them, except I think number 5 and number 10. Number 5 was your assignment. Hope you have studied that. The maintenance of quadrant-wise tooth setting timetable. And number 10 is space maintenance, which we'll discuss today. Before we move into today's class, I want to recap what we are actually doing. We're talking about the procedures that are needed uh, so that we can prevent malocclusion from developing, so that orthodontic treatment will not be required in future. That is the part of preventive orthodontics. So today we'll be focusing more on the space maintenance aspect. One of the points that we said was related to the care for the deciduous teeth. And why we have to take care of the deciduous teeth is because if the deciduous teeth are lost early, the succedaneous teeth will not have space to erupt in the arch. Thereby, the teeth will either erupt buccally or lingually, leading into malocclusion, which I have reiterated time and again in the last class as well. So we know that whenever the deciduous teeth are lost early, we have to preserve the space for the succedaneous permanent teeth. Now let's look at the three situations. Let's talk about deciduous incisors, deciduous canines, and deciduous molars, first and second molars. Do we need to preserve space for all these, or some teeth are more important than the other? So let's look at this picture. Here you can see that the maxillary deciduous incisors have been lost prematurely. So do you think we need to give a space maintainer in this case? This is a question. So I'm looking for your answers. Do you think we need to preserve the space for the early loss of deciduous incisors? I've actually opened the chat box and I'm looking for your answers.
No, sir.
So yeah, some of you are saying no. Yeah, some you can even speak, okay, like Vinamra. So why do you think we need not preserve space for incisors? We need not preserve it. All of you are right. Many of you have written no. So mostly because whenever the anterior teeth are lost prematurely, uh, space loss is very minimal, if any. So if we have to do anything to the early loss of the incisors, deciduous incisors I'm talking about, the only thing we have to do is probably replace them for aesthetic reason or for function reason like speech. For aesthetics or speech, we can replace the prematurely lost deciduous incisors like this. We can use two bands on the molars, and from the bands there will be a wire running from one molar band to the other, and in the anterior region you can attach the pontics or the artificial teeth. And the main purpose is not space maintenance, because space maintenance is not critical in the anterior region. The major reason is aesthetics and speech. Either you can use a fixed type of, let's say, a maintainer like this, or you can use a removable type of space maintainer. Not very critical, okay? You can leave that space as it is, and the space will not be lost a lot in the anterior region. Or you can use a removable type of space maintainer, which is very similar to a removable partial denture, which you will be making in prosthodontics. A denture with teeth in the anterior region. But this is not very important. What about canines? Like if the deciduous canines are lost early, as in this example, do you think, not let's not look at this picture, but generally speaking, do you think we have to preserve space for the prematurely lost deciduous canines? And I'm looking at the chat. So Binama says yes, we have to preserve space for the deciduous canine. Sita and many others. Asta, you're saying yes. Why do you think we have to preserve space for deciduous canine? Prematurely lost deciduous canine. Many of you are saying yes. Even if you're saying yes, my answer would be no. You need not preserve space for prematurely lost deciduous canine. Again, canine is an anterior tooth. So again, space loss is very minimal in the anterior region. But you are right in a way that if a canine is lost on one side, and if you do not stop the incisors from going to that side, there could be midline shift. So probably you have also studied in periodontics that if one of the deciduous canines is lost prematurely, you should extract the canine in the other side as well to prevent the midline shift. So if you want to prevent the midline shift, you have to extract the canine in the other side. Or sometimes if you just want to preserve this space, and you can modify this kind of a lingual holding arch, which we'll discuss a little later, like this, a wire running from one molar band to the other. And then you can attach hooks.
Hello. Excuse me, sir.
Yeah.
Sound is a little bit disturbed, sir. Is it only me or everyone else is facing the problem?
I will not be able to.
Yes, sir. The audio is a little bit disturbed.
Probably it is due to connection. Can you hear me now?
Now it's a little clear, sir. Yes, sir.
Thank you. You keep on providing me feedback because I'm actually talking to the screen, so I don't know how you're listening to me. Okay, so here we will use a hook or a spur from this wire just distal to the lateral incisor so that the incisors would not move distally and there would not be any midline shift. So again, the blunt answer to even canine is you need not preserve space for prematurely lost deciduous canines. Okay, so for incisors and canines, we are not worried about space loss. So we need not maintain this space. The only concern regarding canine is the midline shift. Okay. Now the next situation is when we have the premature loss of the posterior teeth, the deciduous first and the second molar. In the maxillary arch, as you can see in the first diagram, and in the mandibular arch. And the answer is obvious this time that whenever the posterior teeth, deciduous posterior teeth, either first or the second deciduous molars are lost early, we have to think of space maintenance. As I have showed you the animation, probably in the first or the second slide, once the posterior teeth are lost early, then the first permanent molar or at times even the second deciduous molar would migrate mesially so that there won't be any space in the arch for the succedaneous premolars to erupt, which will erupt in malocclusion and orthodontic treatment will be required. So this is the conclusion of what we have discussed till now. If there is early loss of the deciduous teeth, for incisors, we have to only consider about aesthetics and speech. For canine, we have to think about the midline shift. And for the molars, we have to consider space maintenance. So for space maintenance, we are mostly concerned about the posterior deciduous teeth. Those are first and second deciduous molars. Am I audible?
Yes, sir. Audible, sir.
Okay, so we move further. So we are mostly thinking about the molars. When the deciduous molars are lost early, we'll think of space maintenance. Now, when you talk about space maintainers, these are the appliances that are given to preserve the space for the erupting succedaneous tooth or teeth, which are mostly premolars, first and the second premolars. So the space maintainers could be either fixed type that the patient cannot remove, or the removable type that the patients can remove and replace themselves. Again, the space maintainers could be unilateral, meaning if the tooth is lost on only one side of the arch, either maxilla or mandible, or bilateral when the teeth are lost on both the sides of the arch. So there are different types of space maintainers. This slide actually talks about the fixed space maintainers. What we'll do is we'll first complete the fixed space maintainers and then we'll go to the removable type of space maintainers. So there are different types of unilateral and bilateral space maintainers. We'll go and see one by one these space maintainers so that you will understand in which situation we have to give which type of space maintainer. I think the concept of unilateral and bilateral is quite clear. If we have a tooth loss on one side of the arch, we go for the unilateral space maintainer. If teeth are lost on both sides of the arch, we use bilateral space maintainers. Now, this is the situation. Let's say this is the mandibular arch. So on the right side, let's say the first deciduous molar is missing. So this is a case of unilateral tooth loss or bilateral tooth loss. Unilateral or bilateral?
Unilateral, sir.
Unilateral.
Unilateral.
So we'll give, thank you. So we'll give about fixed, okay? So what we will do is we will place some attachment in the posterior tooth, the tooth which is just posterior to the extraction space, let's say, the space distal to the tooth distal to the extraction side, we'll place attachment, and from that we'll have another attachment which will be extending till the tooth which is mesial to the extraction side, like this. And this attachment would actually preserve the space for the erupting tooth. So this is a type of this is an example, or let's say a prototype of fixed type of space maintainer, that is unilateral. Now let's see the example, how it looks like. This is called a band and loop space maintainer. So you can see in this case, the second deciduous molar is lost prematurely. So what we have done is we have placed an attachment, in this case a band, on the first permanent molar, and we have placed a loop, that is a wire which is bent like a loop, and it is soldered or attached to the band on the first permanent molar. This is a band on the first permanent molar and a loop of a wire. This is around 19 gauge wire, which is formed into a loop, and it is soldered, that is attached to the band. And since it is being given on one side, this is a unilateral type of a fixed space maintainer. And the name of this space maintainer is band and loop. So this is a band and loop type of a space maintainer. So how we construct this is, once we decide that the second deciduous molar is requiring extraction, we make the impression, pour the cast. On the cast, we select a band on the first permanent molar. After that, we trim the tooth on the cast like this with a lacron carver or a BP blade, and then fabricate a loop of wire using a 19 gauge stainless steel wire. After that, we attach this wire to the band using solder. The process is called soldering, which you will see when you return to the college, we'll have a demonstration of soldering as well, how we attach the wire to the band. The process is called soldering. So this is band and this is the loop formed by wire, a 19 gauge wire. So we have a band and loop type of a space maintainer ready. Now, immediately after extraction of the tooth, we just seat the band on the molar, that is the distal tooth, uh, and then we check the fit of the appliance. And if we find that the appliance is fitting properly, we cement this band on the molar like this. We use glass ionomer cement or GIC for cementation of the band and loop space maintainer. And after some time, the succedaneous tooth or the premolar would erupt like this through the loop. So this band and loop space maintainer would preserve space for the erupting succedaneous tooth. Since on the distal tooth we have a band and this loop is attached to the mesial tooth, the space between the distal and the mesial tooth to the extraction site is always preserved till the succedaneous tooth erupts into the arch. So this is how a band and loop type of a space maintainer works. Is the concept clear? Any questions till this point you can ask? I'm checking your chat message. Any questions?
Sir,
Yes,
is
sir.
there any chances of failure of the band and loop? I mean, if what if we place the band and loop, but the tooth erupt buccally or lingually, hampering the loop area?
Uh, Means like if the tooth erupts in such a way that it is obstructed by part of the loop.
Yes, sir.
Yeah. So in that case, we have to be like before you make the loop, what you should do is the loop should be slightly wider to incorporate the entire crown of the erupting tooth. But if by chance the tooth erupts slightly buccally or lingually and it is obstructed by the wire, at this point you can actually remove the entire assembly, band and loop, because once the tooth starts erupting and it is being obstructed by the wire means it is almost in the occlusion. So you no longer require the space maintainer. So you can remove it actually. Have I answered your question?
Yes, sir. Thank you.
Mostly this space maintainer is needed when the tooth is still erupting and it is inside the bone. But once the tooth is in the oral cavity, the job of the space maintainer is almost done. Okay. So there is a question from Akshita who says, do we place the space maintainer as soon as extraction? Yes, this is a good question, Akshita. I had a question at the end of this presentation regarding this, the same question actually. The ideal way of placing a space maintainer is once you decide that the deciduous tooth has a hopeless prognosis and it has to be extracted before the eruption of the succedaneous premolar, we first make impression, pour the cast, fabricate the space maintainer, and once the space maintainer is ready, what we do is we extract the tooth and on the same appointment, we place the space maintainer. So this is how we do. We do not extract tooth, make impression, and then send the patient and recall the patient after a few days and then place the space maintainer. We have to place the space maintainer immediately after extraction if possible. There is another question from Asta who says, as permanent canines erupt later than permanent premolars, if deciduous canines shed off prematurely, will the permanent premolar not occupy space for the permanent canine? This is true in, I think, maxillary arch, Asta. In the mandibular arch, the canines will erupt, but the space loss is mostly due to the erupting force of the posterior teeth, which are mostly the first and the second permanent molars. So as we move towards the anterior region, the tendency of space loss is less. So for the incisors and the canines, space maintenance is not that mandatory compared to deciduous first and the second molars. But if you are thinking about it, definitely if you want, and if you think that this case requires space maintenance, you can even think of space maintenance for the canines as well. And there is a question from Vivek who says, in band and loop space maintainer, is there any possibility that the biting force traveling through loop causing the drift of anterior canine and the premolars? So whenever you are fabricating this appliance, you should ensure that uh, the wire or the loop does not come into occlusion. So if the loop is not in occlusion, there won't be the transfer of biting force into the loop. I think I have answered your question, Vivek. Okay, we'll now move on to the next type of space maintainer. Once you have understood the band and loop, other four you will easily understand. The other is called crown and loop. So what is the basic difference between band and loop and the crown and loop is, you will notice by looking at these two photographs, this is the crown that covers the entire tooth. Probably you have experienced crown after you have done the root canal treatment. The tooth is completely covered with the crown. Or if the tooth has had a gross caries and it was restored, if the tooth is very weak, a crown is placed to prevent the tooth from fracturing. So if the tooth already has a crown and the tooth lies posterior to the extraction site, instead of placing another band around the crown, we can simply attach the wire to the crown. Or if the tooth is sound and it does not have a crown, we can place a band. So I think I have made myself clear. Instead of the crown, instead of a band on the posterior tooth, in a crown and loop, the posterior teeth or tooth will have crown and everything will remain the same. Instead of a band here we have a crown. So crown and loop is just a minor modification from band and loop. So instead of a band, we have crown. Is it clear? I think it's a pretty simple thing. Simple modification from band and loop is crown and loop. Is it clear? I'm looking for your responses in the chat as well as any audio responses if you have. Okay, so the thing is, if the tooth is grossly carious, the posterior teeth already had a crown, so you don't have to put a band on that. You can simply attach the wire to the crown. So it becomes a crown and loop. Okay. So this is the difference between the crown and loop, the first diagram, and band and loop in the second diagram. But regarding their action of space maintenance, both are equally effective. It depends whether the tooth already had a crown, you make a crown and loop. If the tooth was sound, it did not have any crown, you make a band and loop. Okay, so we have now discussed about band and loop, crown and loop. The other two are some minor modification of these two. One is called the band and bar. The other is called the crown and bar. I had a question. I think I'll just go back to that question first. And where is that question? Yeah, I think somebody asked that when the erupting tooth comes near the occlusion, it could be impeded by the loop. Somebody was asking that a little earlier. I think it was Praveen. Praveen, was it you? Now, the problem with the band and bar or the crown and bar is that this problem could arise. Instead of loop, here there is bar. So it is said that when the wire, instead of using a bar, if you use a loop, sometimes because of occlusal forces, the loop could be distorted. So for that, a rigid wire is placed between the two bands like this, or from a crown or from a crown, or bar could go distally like this. So these are the two different types of space maintainers. This is called crown and bar. There is a bar. Sorry, these are bands and bar, and this is the crown and bar. Okay, so this is crown and bar. So what happens is when the tooth erupts near this bar, we have to remove this appliance entirely. So the advantage of loop over bar is that through the loop, the tooth can erupt. But if you are using bar, the bar has to be removed. But by the time tooth reaches to this point, you no longer require space maintenance as well. So till now we have discussed about the crown and loop, the band and loop, crown and bar, and band and bar. They are basically the similar type of space maintainers with slight modification. Okay, let me check to the next slide. Yeah. So this is the question, whether should we go for a loop or a bar? Both are equally effective. The bar would impede the eruption of the premolar tooth when it reaches near the occlusion. At that point, you can remove the bar. Loop will allow the tooth to erupt through that loop, but at times, as one of you asked, there could be uh, that disruption in the eruption if the loop is not designed properly. But both are equally effective. So that was regarding a tooth loss where we had a tooth distal to the extraction site. But what happens if there is early loss of the second deciduous molar? As you can see in this diagram, the second deciduous molar is lost early before the eruption of the first permanent molar, meaning we do not have a tooth distal to the extraction site. So this is a difficult situation. Any idea how we can use space maintainer in this case? Anybody? Have you understood the question? We have lost a tooth, that is second deciduous molar, but the first permanent molar has not erupted. Means there is no tooth distal to the extraction site. It is a difficult situation or a unique situation, I should say.
Sir, since the mesial rift is caused by the eruption of molars, and so in this case we don't require a space maintainer. So,
But we said that space maintainer is necessary for the early loss of the first or second deciduous molar, isn't it? So in this case, second deciduous molar is lost early, even before the eruption of the first permanent molar. Means it is around the age of 4 or 5, because the first permanent molar erupts at the age of 6, isn't it? So you mean to say that the space maintainer is not needed? So Vivek and even Akshita say that we do not require a space maintainer, but actually we need a space maintainer in this case. Let me show you how it causes the problem. So if you see this first permanent molar has not erupted, but we know that the distal surface of the second deciduous molar guides the eruption of the first permanent molar into the arch. But if the second deciduous molar is lost early before the eruption of the first permanent molar, this first permanent molar would drift mesially as it erupts. So it will eventually erupt in the position of second deciduous molar. Thereby, we won't have space for the eruption of the second premolar. So it is very important that we have a space maintainer in this case. But then we do not have a tooth distal to the extraction site as a support or abutment. So this is the situation. We have the first deciduous molar. The second deciduous molar is lost early. This is the first permanent molar, which has not erupted into the occlusion, and we have to preserve this space. If we do not preserve it, this first permanent molar would erupt here. It will drift mesially as it erupts. So what we have to do here is we have to give a different type of a space maintainer, which is known as the distal Su space maintainer. This is distal Su, distal Su space maintainer. So what we have done here is we have placed a crown. You can even place a band, depending upon the situation, whether the tooth is sound, you can place a band. If the tooth is grossly carious, you can place a crown. And from that, you can attach a distal attachment like this, so that this distal attachment would guide the eruption of the first permanent molar into its normal position, and this space will be preserved for the eruption of the second premolar. So this is how the appliance looks like. This is a band which will be placed on the first deciduous molar. This will be the space for the premolar to erupt, and this is the distal part of this appliance. which will guide the eruption of the first permanent molar into its arch. Since this appliance goes into the bony socket, unlike other space maintainers, it goes inside the bony socket. This appliance is also known as the intra-alveolar appliance because this appliance goes into the alveolus. Okay, so this appliance is also known as intra-alveolar appliance. So distal sewage space maintainer is also called intra-alveolar appliance. So once you place the appliance like this part is going inside the bone. Eventually, the first permanent molar will erupt like this, and this space will be preserved for the second premolar to erupt. But once the first permanent molar erupts, now we have a tooth distal to the extraction site. So what we can do is we can replace the distal sewage space maintainer with the conventional space maintainers which we discussed earlier. That is band and loop. Now that the distal tooth, the first permanent molar has erupted, we'll band that and create a loop like this and preserve this space. Why we have to replace the distal sewage space maintainer with the band and loop immediately after the eruption of the first permanent molar? Any suggestions you have? Any comments? So you have understood the point. I said once the first permanent molar erupts, after giving the distal sewage space maintainer, it is wise to replace the distal sewage with the conventional space maintainer, that is the band and loop type space maintainer, like this. Why is it necessary? Okay, the answer is the distal sewage space maintainer is an intra-alveolar appliance, and it is difficult to maintain oral hygiene with that appliance. So once the first permanent molar erupts, we'll remove the distal sewage and go with a conventional appliance, which is not inside the alveolus. And it is easy to maintain oral hygiene with the band and loop or band and bar type of appliance. I think I've got an answer. While placing, this is from Vivek, who says, while placing it inside the bone, how can we ensure that it is exactly in between the tooth buds inside the bone? Yeah, that's a good question, Vivek. Let me see if I have slides. Yeah, I don't have it. So I'll just show you this. Yeah. So it is important that whenever we fabricate this appliance, we take a radiograph before the appliance is cemented. So we will just fabricate this appliance in the cast, and we'll sit the appliance in the patient's mouth like this. This band, in this case, crown is placed on the first deciduous molar, and this distal part of this appliance goes intra-alveolarly like this. And at this point, before cementing this appliance in the patient's mouth, we take a radiograph. This is exactly the radiograph that was taken for that purpose. And once we are satisfied with the position of this part, which goes intra-alveolarly, then only we should cement this appliance. Good question, Vivek. I think I have answered your question. Once the appliance is in right position, we will cement the appliance. Yeah. And there is also risk of infective endocarditis. Goes inside the bone, and during its placement, there is a risk of bleeding. So probably we have studied in internal medicine that if you are doing any oral procedure that could induce bleeding in patients who are susceptible for heart diseases, we need antibiotic prophylaxis. Because any procedure that induces bleeding in the oral cavity induces the risk of developing infective endocarditis in patients. So whenever we are placing this space maintainer, particularly the distal sewage space maintainer, infective endocarditis prophylaxis is necessary. Have you studied about this infective endocarditis prophylaxis in medicine? I'm waiting for your responses. Is my audio disturbed still?
So now it is clear.
So I was talking about infective endocarditis prophylaxis. Since this appliance goes inside the bone into the socket, there is a risk of bleeding with this appliance placement. So infective endocarditis prophylaxis is necessary regarding this space maintainer distal sewage. Okay, so there are three unique things regarding the distal zoo type of space maintainer. This is a frequently asked question as well. One thing is, if the second deciduous molar is lost prematurely before the eruption of the first permanent molar, which is the space maintainer of the choice, it is distal zoo. The space maintainer that requires this antibiotic prophylaxis for replacement, it's also the distal zoo. And the space maintainer that is placed inside the bone, that is also distal zoo. Remember these things regarding the distal zoo type of space maintainer. Again, somebody is saying the audio is disturbed. Am I audible now?
So the
Am I
audio,
audible?
sir, time and again, the audio is like a little bit off.
Okay, I'm sorry regarding that. I think if I'm audible, I'll move on from now.
Yes, sir, you are audible now, sir.
Okay, thank you. So I talked about three things. This is used when the second deciduous molar is lost before the first permanent molars erupt. It is intraalveolar appliance and it requires effective endocarditis prophylaxis, that is antibiotic coverage. Let's move ahead. Now, in this case, you can see that the deciduous teeth are lost in both sides of the arch. As you can see, the first deciduous molars are lost in the right as well as on the left side. So it's a case of bilateral tooth loss. So we require space maintenance in this case. One way of doing it is we can give two unilateral space maintainers like this, two unilateral on the two sides. So it is a band and loop you can place on both the sides, or you can use a single bilateral type of space maintainer. Single bilateral, like this. This appliance is known as the lingual holding arch. So there will be bands on the distal tooth, the tooth distal to the extraction site. Let's say in this case, the second deciduous molar will be banded like this. And then a wire will run through one molar band to the other, and it will be soldered to the other band. And the wire will be touching the cingulum or lingual aspect of the incisors. So this is the space maintainer of choice in the mandible when there is bilateral tooth loss. The name of the appliance is lingual holding arch. So if somebody asks you which is the space maintainer of choice where there is bilateral tooth loss in the mandible, your answer should be lingual holding arch. This is the ideal appliance. No doubt you can give two band and loop or band and bar, crown and loop or crown and bar, but this is the ideal appliance. But there is one condition before giving the lingual holding arch, that is the incisors should have been replaced by permanent incisors. There should not be deciduous incisors. Okay. As you can see in this case, I'm actually getting some feedback from somebody, like some birds chirping. Okay, thank you. So in this case, if you can see, lingual holding arch was placed in the patient's mouth before the eruption of the permanent incisors in the mandible. So what has happened is, since the lingual holding arch went through the cingulum of the deciduous incisors, and as we know, the permanent incisors erupt lingual to the deciduous incisors, and with the tongue pressure, they are pushed into the arch. Because of the lingual holding arch, the permanent incisors are now disrupted from moving into their normal position. I think you got the point.
So your audio is very disturbed.
Oh, I'm sorry. I can listen, but am I audible now?
Yes,
am I
sir.
audible?
Yes, sir.
Okay. Okay, thank you. So this is how the permanent incisors erupt in our oral cavity. The permanent incisors erupt lingual to the deciduous incisors. And with the tongue pressure, the permanent incisors are pushed into their normal position, that is in the alveolar ridge. But if you give a lingual holding arch before the eruption of the permanent incisors in the mandible for space maintenance of the posterior teeth, this wire itself, the lingual holding arch itself, will prevent the forward movement of the permanent incisors due to trauma pressure. So one of the implications of the conditions that we have to take into consideration before giving the lingual holding arch is that the permanent incisors should have erupted in the mandibular anterior region. So the condition is, if there is bilateral tooth loss in the posterior part of the mandible, and if the permanent incisors have erupted, then the space maintainer of choice is lingual holding arch in the mandible. So the thing that I want you to understand is, for bilateral tooth loss in the mandibular arch, the space maintainer of choice is lingual holding arch, provided the permanent incisors have erupted. I think I have made myself clear with this. Let's move on now. In the maxilla, if there is a unilateral tooth loss in the maxilla like this, in this case, the first deciduous molar is missing on the right side. Which is the space maintainer of choice? Any answers? Which is the space maintainer of choice in this case? Yeah, yeah, same like mandibular arch. It could be band and loop or any other. It could be crown and loop. Anything else? Anything else? Can we use bar? Definitely, we can use band and bar or crown and bar. So all the four options are possible. I'm just looking at your chat as well. Yeah, band and bar, crown and bar, band and loop, all are possible if there is unilateral tooth loss. What if there is a bilateral tooth loss in the maxillary arch? In the mandibular arch, if there is bilateral tooth loss, we said we will give lingual holding arch. And in the maxillary arch, there is a similar appliance which is known as the Nance holding arch. The same thing, you band the two molars like this, and from the one molar to another molar, we run a wire which will be soldered. And in the palate, in the anterior palate, there will be a button like this, Nance button. So this appliance is known as Nance holding arch. Bilateral tooth loss in the maxillary arch. This is how the appliance looks like. Bands on the distal tooth, and a wire runs from one band to the other. And in the anterior region, there will be a button. That's the Nance palatal button, which rests on the palate. This is how the appliance looks like in the cast. And the same appliance could be cemented in the mouth. So for bilateral tooth loss in the maxillary arch, the appliance of choice is Nance holding arch, similar to lingual holding arch in the mandible. I think this concept is fairly straightforward. But in the maxillary arch, there is another option as well, which is known as the transpalatal arch. In this case, we'll run a wire directly from one band to the other like this. Just a straight wire with one loop in the center of the palate to the other band. So there are two options for bilateral tooth loss in the maxillary arch. One is Nance palatal arch or Nance palatal button, and the other is the transpalatal arch or TPA. So for bilateral tooth loss in the mandible, lingual holding arch. For bilateral tooth loss in maxilla, Nance palatal button or transpalatal arch. Any questions? Any questions, or if you are clear, then I can move ahead. Okay, thank you, Akshita. So these are the options for bilateral and unilateral tooth loss using the fixed appliances. So we have, I think, finished talking about the fixed type of space maintainers. Now let's move on to the removable type of space maintainer. Have you started preparing removable space maintainers in periodontics? Practicals, LabX? Have you started preparing them? Oh, yeah. Asta says yes. So I think you are familiar with this appliance. So it will be much easier for me. So it is like acrylic based plate, and as you can see this extension, this extended part represents the area which is edentulous. That is, the tooth is lost early, and with the help of clasps on the adjacent tooth, we are trying to preserve this area like this. So this is a removable type of space maintainer. As you have started preparing those appliances in periodontics, it is much easier for me now. Again, the audio is disturbed. I was talking about the removable type of space maintainers. This part of acrylic represents that the tooth is lost here, and with this acrylic flange, we are trying to preserve the space. Now see, in this example, the first deciduous molar is lost early. Am I audible? Is the audio okay?
Yes, sir.
Okay, thank you. So in this case, you might be tempted to give a space maintainer like this, shown in the second diagram, which has clasps. One will fit in the second deciduous molar, other will fit in the canine. But never ever give a space maintainer like this, because this space maintainer is relatively small and this could be swallowed by the patient. So whenever you are giving a removable type of space maintainer, please ensure that it extends the entire arch. So it should have attachment in both the sides of the arch, right as well as the left. Okay, so do not give a small space maintainers like this, because there is a risk of patients swallowing this type of removable space maintainers. So we'll give a removable space maintainer like this. And if this removable space maintainer extends like this in the edentulous area, and we do not have any tooth or teeth in these edentulous areas, then this type of removable space maintainer would be called non-functional removable space maintainer. But if you also set the teeth in the edentulous area like this is the same similar type of removable space maintainer, but in the edentulous area, here we have teeth for the patient to chew. If we do this with the teeth setting on the removable space maintainer, the removable space maintainer would now be called as functional removable space maintainer. So removable space maintainer could be of two types, functional or non-functional. If just the acrylic is extending without any tooth or teeth, it is non-functional. But if you also set the teeth in the edentulous area, it will be called as a functional removable space maintainer. I think today's class, the content is now almost over. Any questions? If you have, I'll take the questions at this point. Any questions? So what we have discussed till now is we have talked about two different types of space maintainers, fixed and the removable type. In the fixed as well as the removable type, we have also discussed about unilateral as well as bilateral space maintainers. We have talked about indications of different types of space maintainers. If I have to summarize some of the space maintainers, the first would be band and loop, the other would be band and bar. Crown would be the similar modifications of that. One of the unique type of space maintainers is the distal shoe space maintainer. You should remember its indication. When the second deciduous molar is lost early before the eruption of the first permanent molar, you will go for the distal shoe. You should also remember that this is an intraalveolar type of space maintainer which goes inside the bone, and you might require antibiotic prophylaxis. Those were unilateral space maintainers. But if you have tooth loss in both the sides of the arch, you need bilateral space maintainers. In the mandible, you can use lingual holding arch, but remember that before placing the lingual holding arch, the mandibular permanent incisors should have erupted. In the maxilla, you have transpalatal arch or button and transpalatal arch for bilateral tooth loss. Then we briefly talked about the removable type of space maintainers, which could be functional or non-functional. So this is the summary of the class. So these are some of the questions that I have. When to insert a space maintainer? So can anybody tell me when is the right time to insert a space maintainer? Anyone? Am I audible? Is the audio disturbed? I got a response from Akshita, who says when there is early loss of the deciduous tooth, loss of deciduous first and the second molar, that is all right. But when is the time? Like you are losing a tooth. So when
So
is the
immediately after tooth extraction, I guess.
Yeah, immediately after the tooth is extracted. So I have also answered this question before in this presentation when Akshita asked the question earlier. That is, if we now know that the second deciduous molar, or let's say first deciduous molar, is grossly carious, and we have to extract it, then what we do is we first make impression, pour the cast, have the space maintainer ready, and then only we extract the tooth, and immediately after extraction we place the space maintainer. Okay, so the answer is immediately after extraction. So don't just extract the tooth, then make impression and call the patient after some days for the space maintainer to be inserted. Okay, so that is the answer I was looking for. Immediately after loss of the tooth or extraction of the tooth, this is the right time to place the space maintainer. Why we are doing this is because the maximum space loss occurs within 6 months of tooth extraction. So if you have not placed a space maintainer for 6 months, now there is no point placing a space maintainer because the space loss would have already occurred. Okay, so you have to place the space maintainer immediately. But if you do not place a space maintainer for some time, let's say for 6 months, the teeth would have drifted into that site and the space would have been lost already. In that case, you have to use appliances called space regainers. Now the space maintainers will not work. You have to regain the lost space. And so for that, we have to use space regainers. Again, space regaining is an interceptive procedure, not preventive, which we'll discuss during interceptive orthodontics. So if the space is lost, we have to use space regainer. Am I clear with this point? If the space is not lost, space maintainers, and if the space is already lost, then we go for space regainers. Okay, thank you. And this is another thing that we have to be very careful of. Before giving any space maintainers, we have to look at the radiograph, the orthopantomogram of the patient. For example, in this case, there is no tooth board of the second premolar. As you can see in the mandibular arch, we do not have tooth boards of the second premolar in both the sides. And in this case, if the second deciduous molar is lost early, and if you preserve this space, there won't be any premolar to erupt. So in this case, it is better to allow the first permanent molar to drift in the arch and to occupy the space of the second deciduous molar. So always look at the radiograph before giving any space maintainer, whether there is a tooth board for which you are giving the space maintainer. So it is important that you look at the radiograph before giving any space maintainer. I can see some of your questions. I think we'll discuss that at the end. Now, this is the final question for the class. Which is the best space maintainer? We have talked about a lot of space maintainers, isn't it? So which is the best space maintainer that we can give for a patient? Anybody? I'm looking at your chat as well. If you want to come directly, you can use audio as well. So this is the question. Which is the best space maintainer? Asta says band and loop, band and bar. band and bar. Any other responses? Band and loop. I think I have been able to trick you here. Yeah. Okay. Yeah, that's correct, Aksita. That's correct. Am I audible now? I'm getting feedback like my audio is disturbed again. Am I audible?
Yes, sir, audible, sir.
The best space maintainer is the deciduous tooth. So if you care the deciduous dentition, you won't have to think about any type of artificial type of space maintainers. So this is also one important question that they ask in multiple choice questions, like which is the best space maintainer? The deciduous tooth is the best space maintainer. So once the deciduous tooth or teeth are lost early, then we have to think of artificial space maintenance. So we should take care of our deciduous teeth. That is the message of this class. I think that is the most important message. Any questions now? I will also go to your questions in the chat. I'm trying to access them. In the meantime, if you have any questions, you can ask.
Sir, is there any chances that even if we use a space maintainer, then also a patient will get like maloccluded teeth in later age?
Is it
Yeah.
Praveen? Praveen? Is that you?
Afroz, sir, Afroz.
Okay, so you're saying if you give a space maintainer, even if with the space maintainer, is there a chance of malocclusion developing? That is your question?
Yes, sir.
Praveen, with the space maintainer, we'll preserve the space for that particular tooth, isn't it? So that tooth will probably erupt in its normal position. But there could be malocclusion somewhere else in the arch. That is one thing. And the other thing is, if the tooth board is in an abnormal position, even if you are placing space for its eruption, that particular tooth could erupt in a different position, leading to malocclusion. So the whole point is, with the space maintainer, you are preserving the space for the tooth to erupt. And if the tooth board is in normal position, it will erupt in the arch. So with the space maintainers, there is a high chance that malocclusion of that particular tooth will be prevented. But in some cases, that particular tooth can erupt in abnormal position, provided that the tooth board is in abnormal position. I think I have answered your question. If you have any follow-up question, come again. So
Yes, sir. Thank you, sir.
thank you, Praveen. So there is a question from Vivek in the chat. So he says, in one case, you said that due to the risk of distortion of loop, we use band and bar types. So in this case, won't the distorting force, which is coped by bar, put stress upon the tooth adjacent to the bar? So, Vivek, what I was trying to say is with the both the loop and bar would not be in occlusion. So while inserting that appliance, when we fabricate the appliance, we sit the appliance in the patient's mouth and check for the occlusion, whether the bar or loop uh, is in occlusion or not. If they are in occlusion, we ensure that they are not interfering with the occlusion. And once we are satisfied with that, we cement the band in the patient's mouth. So even with that, as the wire length increases in the loop becomes flexible. So when the person is chewing, due to the forces of the food, that is the bolus of the food that the patient is chewing, there is chance of loop being distorted. This is a rare chance. So if we are concerned about that, you can go with the bar, but even the loop works. So what the proponents of the bar say that since the loop is flexible, it can be distorted. So you can go with the bar, but both can be given. So that is my answer.
Sir,
Vivek, yeah.
sir, I was talking about angular forces, like not an occlusal forces, but angular forces.
Means whenever the person is biting on certain food items, the force could be exerted on the loop, and that could apply force to the adjacent tooth, isn't it?
Yes, sir. Yes, sir.
That force is always there and it cannot be prevented.
Okay,
We should
sir.
we should avoid the direct occlusal force, but those type of forces cannot be prevented. A good question, Vivek.
Okay, sir. Thank you, sir.
You're welcome. So I'm checking other questions. There is a question from Omi who says, if there is bilateral tooth loss in maxilla, we can use either of Nance holding arch or transpalatal arch. Both are same. Yeah, you can use any of the two, Omi. Uh, in the literature, what they say is that Nance palatal button, since it takes support from the anterior part of the palate, it provides better support. But there are studies which say that transpalatal arch is equally effective. So you can use both, either the transpalatal arch or the Nance palatal button. One problem with the Nance holding arch or Nance palatal button is that since you are placing an acrylic button in the palate, there could be oral hygiene problems underneath that button in the entry part of the palate. But if the patient maintains the good oral hygiene, both are equally effective. So you can use either transpalatal arch or Nance holding arch in the maxillary arch. I think I have answered your question. If you want any explanation, you can come with your questions again in the chat. There is a question from Renu who says, can we use space maintainer after 1 to 2 months? Renu, as you have said, uh, during the first 6 months, the space loss is very rapid. So it is better to give a space maintainer immediately after extraction. But if you want to give it within the first 2 months also, that is okay. Prevent further space loss. Because let's say you have a extraction space of, let's say, 8 mm for the premolars to erupt. Within the first 1 or 2 months, maybe 2 or 3 mm space would be lost, and you will be left with only 5 mm of space. At this point, if you give space maintainer, it will at least maintain that space. And later you can give a space regainer to gain the 3 mm space that was lost. But if you do not give any space maintainer, then the space could be reduced to 1 or 2 mm. And to gain a large amount of space, it could be difficult. Or if you see that the substantial amount of space loss has already occurred, then instead of giving a space maintainer at 1 or 2 months, you can start with space regainer immediately. We'll discuss about space regainer in the interceptive orthodontics. I hope I have answered your question, Renu. You have to look for the space that is remaining. If, if even after 1 or 2 months, if there is enough space for the eruption of the premolar, give the space maintainer. If you see that the space loss is substantial and the premolar cannot erupt, go with the space regainer. I'm looking for further question. Deciduous tooth is the best space maintainer. That is correct. What is Nance button made up of? This is a question from Pragya. Pragya, Nance button is a simple appliance which will have bands on the molar. One wire will run from one molar to the other. And in the anterior region, you will just do acrylization with the cold cure acrylic. That button is made of cold cure acrylic. I think I have answered your question, Pragya. So this is the end of questions I have in the chat box. Any questions or any comments you have? So you have understood different how different type of space maintainers work and in which condition which type of space maintainer is necessary. There is a question from Astha who says, are there any alternatives to distal suey space maintainer? Unfortunately, we do not have the alternatives. There are modifications of distal suey space maintainer, Astha, but we do not have any alternative to distal suey space maintainer. We have modifications like the distal suey space maintainer that we use is by Roche, is given by Roche, the Roche type of distal suey space maintainer, but there are different modifications of the distal suey space maintainer. So it will have a cantilever mechanism, meaning there will be a mesial tooth which will act as a support, and from that a distal hook will go into the intraalveolar region. I think I have answered. So there is another question from Altaf, says, what if there is bilateral loss of deciduous canine? Is there a chance of mesial drift of the deciduous first molar? What will we do in this case? Yeah, there is always chance of mesial migration of the tooth. Okay, so deciduous first molar could move mesially. So if you are concerned about the space loss, in that case, definitely you can go with the space maintainer. The space maintainer of choice would be a lingual holding arch, since there is bilateral tooth loss. So you will have a lingual holding arch running from one molar to the other, and just distal to the lateral incisor and mesial to the first permanent molar, you can attach hooks from the lingual holding arch. One hook would be distal to the lateral incisor, which will prevent the distal movement of the lateral incisor, and another hook would be attached from the lingual holding arch to the mesial aspect of the first deciduous molar, which will prevent the mesial movement of the first deciduous molar. But generally, in the anterior region, the space loss is not that significant, which warrants the space maintainers. But if you are very concerned, then definitely you can go with the space maintainer. Or you can even go with the removable type of space maintainer that you are making in the department of endodontics. So there is a question from Vivek who says, what to do in case of 2 or more teeth loss? 2 or more bilateral. If they are on the two sides of the arch, you can go with the bilateral. If not, you can go with the unilateral. So it's the same band and loop or band and bar. So if, let's say if you have lost first and second deciduous molar on the one side of the arch, and you have the first permanent molar, so you will band the first permanent molar, and the loop will extend from the first permanent molar to the distal surface of the deciduous canine. So you will preserve the space for the first and the second deciduous molars, which have been extracted or exfoliated. I think I have answered your question, Vivek. Any questions? Probably you will also have a class in I think periodontics regarding the space maintenance. And if you have more queries, probably you have understood what is needed at this level. But if you have questions, that can be clarified in that class as well. Any questions? I think it's already like 11:15. I also have to go to the department. So if there are no questions, this is the end of the class. Thank you so much for attending.